Hey, Shuja.
Hey, how are you?
Good. How are you?
Good. I think we've got a few people who've dialed in early.
Yeah.
Um, all right.
Hi, can you hear me, Freddy?
Hi, Julia. Yep,
How are you?
good.
Did you want to use video? Oh, there we are. Great.
And you can hear me okay? No lagging, right?
Hey guys, how are you?
Hi, Shuja, how are you?
Hi.
Good. All right, we got 5 minutes. I think we've got already have like 10 people on early.
Nice.
Cool. You guys sound good. You look good. Cameras are good. Sound is good.
Yep, sound is okay. 1,
Yeah.
2, 3, testing. Great.
Perfect.
Sounds good.
Ready?
All right. We'll give it a few more minutes. I will be right back.
Awesome.
It's good.
Are you glad your calls are over for the week?
Yeah, it hasn't been too bad.
That's good.
One nice thing about this is a lot of the normal things that would happen, like elective surgeries and stuff, would not happen.
So cool.
I forgot to ask if you wanted to mentor a judge this weekend.
We should send out a notification for that.
Okay.
And yeah, and we'll post it through the channel. So if you, do you have a list of like kind of areas of expertise you're looking for mentorship or judging?
Yeah, let me connect you with our co-leads for coordinating that, and they can definitely share much more than I can
Okay.
what we need. I know they've been pretty hard at work about that, so.
Yeah. So if you send that across, I think you send it to Serena, and then we'll make sure this gets like emailed out to folks who are interested in participating, right? So
Sounds good. So to you and Serena, anybody else?
I think if you just send it to both of us, then we'll make sure it just gets distributed out, right?
Okay, sounds great.
And you're on our Facebook group and our Slack?
I think I may have been on your Slack. I don't think I'm in your Facebook group.
Okay, so it's group/MIT CNC. And you can like feel free to post it over there as well. I will put it in the chat window.
Perfect.
Freddy, whereabouts in New York do you live?
96 between Park and Madison. So border of like Upper East Side and East Harlem. Yeah, 2 blocks from the hospital.
I see. It's gotten pretty quiet, huh?
Yeah, no, it's kind of eerie when there's nobody out on the streets and there's no, yeah. Everyone's in shelter in place at this point.
Right.
But yeah, our hospital is building up new temporary like hospital units, rooms in the lobbies of our hospitals to add capacity. I don't know, I think that's gonna be, I don't know what the limit is. I guess I can talk a little bit more too once we get started.
Mm-hmm. Yeah. Yeah, thank you so much. Are you in the hospital then? Is that a room in the hospital you're in?
Yeah, it's just our break room in the residence room. So sure,
Right. Well,
we'll start.
Yeah. Sure. How about we give it another minute for folks to join? It looks like I'm just watching the numbers. And then for those of you joining right now, we will be monitoring our Q&A box. So as you have questions, please feel free to type it in the chat, the Q&A. Is it the chat or the Q&A box? That they should use? Q&A. All right, Freddie.
You ready?
Give it a few more seconds. Let the stragglers join.
Sure.
Alrighty, ready to rock and roll?
Sounds good.
Great. Thank you so much, Freddie. I know that this is quite the unprecedented time that our country and the world is going through. And, you know, there's no one else that we'd like to hear more from than our very own who are on our front lines. You know, you're really our foot soldiers in this war against this invisible enemy right now. So just want to really thank you for your service and contributions right now. I think now more than ever, we are realizing just how paramount and how dependent we are on our medical professionals and essential workers. So thank you so much for being on the line with us today.
Yeah, my pleasure.
All right, could you introduce yourself? Tell us a little bit more about your background and your involvement with the current pandemic.
Sure. So my name is Freddy Nguyen. I'm currently a resident at Mount Sinai Hospital, New York, also a postdoctoral fellow with MIT. So splitting my time between both places, already challenging enough as it is, but definitely during this pandemic has been even more challenging. Prior to that, I did my MD PhD at University of Illinois in Urbana-Champaign. So far, as being in the pathology department is probably one of the areas that most people don't hear a lot from and about, but essentially you can think of as running not just what you normally think of, you know, histology slides or whatnot from tissue specimen or autopsy service, but we are basically running all of laboratory medicine. So all of the COVID-19 testing is happening in our labs. Of course, all the COVID-19 related autopsies happen through our department, as well as now the new area, which is on the treatment for COVID-19. So some of you may have heard about convalescent plasmas being a potential treatment for COVID-19 that's being explored right now, is also being run through our transfusion medicine, which is part of the pathology department here at Mount Sinai. So, and I think a little bit additional background is, you know, I've been involved with a group called MIT Hacking Medicine at MIT for the last 3.5 years now. Was co-director of that group for a couple of those years. And then recently, as some colleagues and students at MIT and I started talking about what was happening, and this was about, I would say, a little over 2 weeks ago, right when some of the initial kind of directions from MIT were about potentially sending students home and away from campus. At that point, they hadn't shut down the research labs or most of the university yet, and so it was still very early. But as we were starting to see that, we were really thinking, you know, there's now a lot of people who are basically feeling this sense of helplessness and idleness, wanting to help in the situation. A lot of especially smart, bright people that fit into that category. And there was, on the flip side, on the clinician side, there's a lot of unmet problems that need to be solved. And so we wanted to figure out a way to bring those two ends together. So that's how we came up with the MIT COVID-19 challenge.
That is wonderful, and really just a true illustration of the creativity and the innovation that the MIT community exhibits during crises like these. So thank you so much for your involvement in that. So the first question I want to ask for you is, and you're in New York City right now, right?
Yes.
What's it like being on the front lines and seeing your city the way it is right now? How is the morale?
I think as you can imagine, the morale is still holding up, I would say. I mean, I think, you know, New York City has always been a tough city. It's always been risen up to the occasion of meeting the challenges. And I think as a city, we've certainly done the best we can. I think Mount Sinai in particular has certainly stepped up in that game as well. I think we were one of the first hospital systems in New York to have our own in-house testing developed for COVID-19 instead of relying purely on LabCorp and the health department to run the COVID-19 testing. And so, and you can see that even just the numbers that are being reported, even though you're saying that high numbers are being reported in New York State, that's largely due because we've expanded our testing capabilities across the city and across the state on a much wider scale than other states and cities have been able to do. And so, yes, of course, we're going to catch, essentially, you know, detect more people having quote unquote COVID-19. So, but even the convalescent plasma treatment that I mentioned earlier, you know, that was probably a week in the making, and we transfused our first patient just this past Saturday. So, one of the first health systems in the, probably I think in the country now that's been doing that.
Great. And going back to your introduction about this COVID-19 challenge, could you tell us a little bit more about what exactly is going to be happening and unfolding over the next couple of weeks? And for those listeners on this call, you know, is it too late for them to get involved?
Yeah, so the COVID-19 challenge, I mean, the way it came about is at first we were thinking, well, virtual hackathons are a perfect scenario to marry those two. Both the people who can solve the problems and the people who have the problems, right? And it's making it virtual is, of course, a necessity, especially now at this point, as more and more places shut down and more that we have shelter-in-place orders around by different states and cities. But there was a few different aspects of it that we knew we had to address from the get-go. As you've probably seen, there's no shortage of virtual hackathons going up every weekend. But what's unique about ours is the first is that we want these to be a series of virtual hackathons. So it's not going to be a one-off like the most typical hackathons you see, and then you kind of wonder like what's going to happen to the idea afterwards. So, and the reasoning behind doing a series of these virtual hackathons is really that we want each hackathons to be hyper-focused on a smaller subset of problems that were super, super pressing at that point in time. We're quickly realizing that the pressing problems are today hopefully are not the pressing problems, you know, 2 or 4 weeks downstream. But vice versa, the most pressing problem a month from now may not even be in our radar today. And we wanted to continue to provide this forum to be able to do that rapid innovation, rapid solution development and implementation of these solutions. So that was sort of one reason that we went with these series of virtual hackathons. So to answer your question, technically, no, it's not too late to join. Our applications right now that we have up is really essentially acceptance into the full series of these virtual hackathons. The second aspect is that we, you know, at Hacking Medicine, we usually bring in a very diverse group of people to essentially form these hacking teams. And you think about essentially every stakeholder of the healthcare system being represented. So we usually want as even distribution as possible between clinicians, scientists, engineers, programmers, user designers, patients, payers, again, business, finance, every part of the healthcare ecosystem, we want to have representation there because they all need to be at the same table, from the co-definition part of the problem to the co-development of the solution to the implementation aspect as well. But of course, in this current context, we also really recognize that we would not get the propensity of healthcare workers or providers as well represented in our hackathon as we would otherwise. And so another thing we've shifted to is that we have formed partnerships with several clinical partners who have been tasked not only with the problem sourcing and prioritization, then also providing mentors to the event, but also examining their implementation pipeline and really taking a closer scrutiny as to how can we do rapid implementation of these ideas? How can we remove all the unnecessary hurdles? How can we streamline, optimize that process so that if we get a great idea coming out, it's well developed enough to be implemented, that doesn't sit there in mid bureaucracy and administrative burn and take weeks before it can even see the light of day. And so those clinical partners, I think, are really key on both sides of the hackathon, so to speak, both in terms of problem sourcing and then on the implementation side. And the partners that we're working with are National Brigham, or what was previously known as Partners Healthcare, so covering both MGH and Brigham and the other hospitals, the whole national VA system across the country, Oregon Health Sciences University, Universal Health Services, Weill Cornell Medicine here in New York, and then looks like hopefully as well Johns Hopkins down in Baltimore will be joining as a clinical partner. So I think that structure has been really powerful. I think the third aspect that's differentiated us from again other efforts, similar efforts that are out there, is that our focus is not on just the hackathon itself, but also that post-hackathon period. The hackathon is meant to really do that team formation, bring in creative new solutions to the table, building out a viable concept, not just from a technical or clinical perspective, but also from an implementation or feasibility perspective. But also that post-hackathon period where we're going to now take these viable concepts, initial prototypes, into something like I mentioned before that can be much more ready to be implemented by the hospital system, so that it's not that on the second or third attempt of using the solution that it's going to break down, or there'll be a bug, or that it becomes unusable, right? So we still wanted to go through enough of that due diligence to have enough of a high quality caliber product to solve those problems.
That's incredible. And it sounds like from what we're hearing, the collaboration between the public and private sectors and between hospitals has just really been so powerful, where doctors, Italian doctors are talking to Chinese doctors, are talking to American doctors. Have you experienced that to be the case?
Yeah, it's certainly been true that at this point, there are no boundaries, so to speak, right? Like, this virus is going to affect all of us. I mean, if numbers are right, that 60 to 70% of the population will ultimately get infected by this. It's, it has no boundaries, it has no borders. So I think it behooves us to come together as a community, as an ecosystem, to really tackle these problems. And I think that's even evidence in even how we built the COVID-19 challenge. We certainly could have done it within any one of the single groups at MIT. I mean, hackathons and hacking is part of the culture at MIT, right? So, but we took the route of really bringing the MIT community together. I think that's been one of the unique things, that it's been a collaboration between Hacking Medicine, the Martin Trust Center of Entrepreneurship, the MIT Innovation Initiative, the MIT Industrial Liaison Program, and Biotech Group, Sloan Healthcare Club, and so on. And the list just goes on and on in terms of MIT entities that are involved in really unifying the MIT community together, which is why I'm really pleased to have the opportunity tonight to also engage with the alumni groups as well. But even in the overall healthcare ecosystem as well, that we've been able to bring to the table, not just the clinical partners, but incubators, accelerators, programs and entities, payers, big pharma, big tech, as well, that have really all come together or rally behind this. And I think, if you went to our website and took a look, they all provide a different added value to solving this problem. And I think if we all come together, just like in our hackathons, to tackle these problems, we'll be able to make a dent in this whole crisis.
Right. And I'm just I put in the chat box, but it's the COVID-19 challenge.mit.edu for our audience to check this out. So it says on the website, the two challenges here are to first protect vulnerable populations, and second, support the health system. So are those the two initiatives and those two, I guess, the outcomes for success of this hackathon?
Yeah, so I mean, I can go definitely a little bit more in depth into exactly what those. I mean, even from those, it's already still sounds very, very broad in terms of what that means. And so for us, when we talk about how to protect vulnerable populations, or really the at-risk populations, we don't necessarily mean just from probably the traditional sense of like, oh, the elderly population or people who have comorbidities in terms of respiratory conditions or compromised states that would put them at higher risk for complications from COVID-19 infections. But really, it's thinking about, also the healthcare workforce who's at higher risk because they have more repeated exposure to patients with COVID-19, or thinking about people who may not be geographically or socioeconomically be able to have access to be near enough to a major hospital that can manage COVID-19 patients, right? So thinking along more of those verticals as well in terms of the vulnerable populations. And then really, I think the aspects there is not just protecting them, but essentially the whole spectrum of, how do you identify who those people are? How do you triage them into even low risk, high risk, medium risk in terms of their risk for complications from, even getting the infection to begin with or the complications from it. And then thirdly, how do you monitor how those patients are doing or those individuals are doing and be able to hopefully catch them earlier when complications do occur. And of course, being able to protect them to begin with from even contracting the infection would be, of course, ideal. But I think at this point with community spread of COVID-19, it's highly unlikely that we'll be, how well the job will be able to do there. The second problem, which has been how do we best help health systems, I think falls under probably two major categories. One has been essentially how do we better help the workforce, the healthcare workforce, right? Like right now, our entire workforce is basically working 24/7 around this. And, we're expecting these to continue for weeks and months. And at some point, our workforce is going to get burned out at some point. And so taking care of our workforce is going to be a hugely important part. So the well-being of our workforce is one aspect. The other has been, as we shift different needs of the hospital or the health systems around. So the example I always give for right now is, we've canceled elective surgeries across most hospitals now. How do we redeploy that workforce into other parts of the hospital based on their skill set so that they are best used, so to speak, whether it's those nurses, whether it's techs, whether it's the physicians that are there, what's the best use of that human resource. Similarly, a lot of hospitals have sent home a lot of their non-essential personnel to work from home, so to speak. Are there ways that we can essentially add very quick educational types of training to enable somebody to now do a very well scoped out, clinical procedure, for example? The example I give is, for us in pathology, running these COVID-19 testing is one thing, but we can't do anything if we don't have an adequate specimen or nasal swab that's not only enough quantity, but of enough quality so that the cells aren't destroyed by the time that they get to us. It turns out people actually do have to undergo training to take an appropriate nasal swab, and at Mount Sinai, we were certainly going through a shortage of that, and we had to go through and train volunteers to do that. But that's a very small scoped out work, but now you don't need necessarily a nurse to do it or a physician to do it. And you can essentially free up the higher skilled labor to really focus on the management of those patients. The second part has been more on, so this is basically resource allocation within human resources aspect. The second part is also similar to resource allocation, but as from the materials and supplies and equipment aspect. So most of you have heard a lot about the shortages in PPE and ventilators. And so that's just one aspect of it. It's trying to figure out not only how to necessarily make alternative solutions or alternative masks, but even how do you think about the supply chain pipeline? How do you now go from probably ways where it was very much centralized manufacturing, distribution networks to now a very decentralized network of sources of this equipment, or even how to find other uses for equipment that could serve as a ventilator, for example, but that was not its primary use, right? So being creative about that aspect of it too. So I think, management of that is something that we should also be looking at, not just how to make more or how to make alternatives of these as well. Because I think few people also realize that, as much as we want to have everyone make these at home or in their companies or whatnot, we still can't necessarily sacrifice the quality and the safety standards of these products that are being put into our hospitals, right? I mean, the worst thing we can do is have people make masks that, haven't had the proper evaluation and have our healthcare workers be using those thinking that they're safe from aerosolization of the COVID-19 and then finding out that they're not. So I think, balancing those acts of getting those supplies as quickly as possible to our healthcare workforce, but also at the same time, still having a little bit of that due diligence on the quality and safety standards as well.
Right. And, as a general public, we've been reading and hearing a lot about the PPE shortages and the different, in a way, ad hoc policies that are being implemented across the country. It's at your hospital. How is your institution advising and supporting this? Is there a universal masking policy? Is there, quality control? Are you guys, I've even heard of hospitals taking donations from the public, from private citizens who have been hoarding N95 masks.
Mm-hmm. Yeah, so I mean, our hospital system, it's certainly anybody that's in direct patient contact, definitely at this point now is required to wear a mask, obviously not N95 mask, the surgical masks have been fine. N95 is more reserved for aerosolization types of procedures at this point. Those certainly are some of our healthcare workers who feel not as comfortable with surgical masks have been allowed to access N95s, but we've all been constantly mindful of trying to use them as long as we can, of course. But I think our own supply right now has been much better in this current week than in prior. We recently got a huge infusion from both N95 masks and surgical masks. I think at the end of last week, I think we had definitely like 500,000 N95s now in stock, and then over 1.3 million in surgical masks. So I think that's starting to come, but that still has to keep going in terms of inflows. And so our hospital leadership has certainly been thinking on a bigger scale to source that, because simply we're one of the largest health systems across the country right now, and we have 8 different hospitals that sit underneath the Mount Sinai Health System. And so, as much as I think the system appreciates donations from the public, I think they still do take that. Just thinking about just the sheer scale of our system and our workforce, even that process starts to become a little bit cumbersome in a sense, because there is no easy way, essentially, right? It's not like they can go to a single point person who then maintains all these decentralized sources that are coming in and organizing that and coordinating that. And I think that's where you're seeing a lot of problems across the country as well. It's like people are making some, people have their own that they're donating in, but there's very little coordination efforts that are happening. I was talking to some of my colleagues in the partner system, and there's so many efforts happening within each hospital that even across the system, like between what's happening at MGH versus what's happening at Beth Israel or Boston Children's or the Brigham. And I was talking to different people at different parts of it, and they were all trying to do something around PPE, but they never talked to each other. So I think that's the part that right now has been one of the big challenges, is that we're all scrambling to this, and not saying that we're necessarily competing, but we're not also talking to each other and coordinating our
You're not
efforts.
sharing best practices.
Right.
Mm-hmm.
And it's not because we don't want to, it's just we don't have the time. Like these systems are looking at like, we need these things like now, yesterday, not a week from now.
right? For those listening, that sounds like a ripe challenge for the COVID-19 challenge, is that coordination, right? And just sharing those best practices and making the system a little bit more centralized. And that
I mean, even right now, some of the best practices are being shared in Facebook groups by doctors that have joined, right? It's not even coming down from any kind of coordination level across hospital systems, or even from the federal government in a sense.
Right. So, I actually want to push on that topic a little bit. So every doctor that I've spoken to seems to have a different favorite source and source of truth, right? Whether that is Fauci or the CDC or WHO. I mean, who has been your personal, I guess, source of truth? And I guess in general, does Mount Sinai look towards a certain source over another?
I mean, I think Mount Sinai in general tries to take a very holistic approach in terms of where its sources are coming from. I think obviously Dr. Fauci and the NIH, I think he's spoken very clearly about the needs, and I think has been very truthful about the pandemic. WHO is, of course, another highly reliable resource. The CDC as well. And I think, as long as we take everything in context and in a holistic manner, like, we usually have a pretty good sense of what's happening. But I think even because, as we can see, this has very much a geographic dependence, right? Like right now, we first thought that Massachusetts and what was happening with the Biogen conference was going to be the epicenter of how COVID-19 first came out. But they've managed to stay actually fairly stable once they've maintained that outbreak. And now it's New York and New Jersey, or even before that, it was Seattle, right? And what was happening in Washington. But now it's New York that's popped up as the next big spike. And so we can see how even within the United States, different parts of the country are at different phases, essentially, of the pandemic spread, right? And so I think it behooves the cities that have been at the forefront of it to do a lot more of that sharing of the best practices and how to manage and how to think about it, and hoping that the other cities and states learn from that and adopt some of those learned lessons a lot earlier than we have.
Speaking of geographical situations, New York City is maybe a harbinger for some other major cities, right? As what you're going through right now. What advice do you have for other cities and other, doctors who are a bit, sitting on the edge of their seats right now, just trying to anticipate what's to come? What advice would you have for them?
You mean for doctors who are potentially anticipating a similar surge, or?
Yeah.
I mean, I think right now you get all the rest you can get before any of this hits. And really, again, as I mentioned earlier, the well-being of our healthcare workforce is first and paramount. If you, obviously the social distancing and isolation process, like, of course, we highly encourage that. If you don't need to interact, then don't. And because we're going to need healthcare workers who are essentially in our reserves, right? Hopefully this doesn't spread too much further, but like I said, we're all going at a marathon speed at this point. And how do we make sure that we can go for not just a few days or even a few weeks, but for months at a time to be able to sustain this, right? Luckily we're now having, I think the USS Comfort just docked into our harbor on Monday. And so that brought in like 1,200 more medical professionals. Even the state has been looking at how to, a couple ways. One has been to figure out how to re-enlist people who have retired from the healthcare workforce back into the service, so to speak, to help accelerate whatever accreditation or liability type of insurance that needs to happen to get fast-tracked. But some of you may have also heard that the medical schools around New York City have been graduating their fourth year medical students early so that they can essentially start their residency internship within wherever they want, wherever they are right now, so that we can use them as well as additional healthcare workers and providers. But I think at this point, if your area hasn't been hit hard yet, and you're not being pulled to the front lines, is, you know, essentially conserve that energy, conserve that rest, you know, and you know, keep yourself healthy, and then we're gonna need you downstream for sure.
Now, does that mean in New York, there's, you know, earlier you had touched on a redeployment of resources and allocation. Are you seeing a lot of providers working alongside you who are not general internists and specialists from other fields who are coming in to be a part of the front line?
Yeah, so at Mount Sinai, pretty much every non-essential department has been redeployed into, whether it's emergency department or internal medicine departments, to be alongside the internists in terms of managing COVID-19 patients. But what the other part people forget is, you know, we still have to take care of all the non-COVID-19 patients. Like, that patient population hasn't gone away, right? So, so I think that complicates things further. But certainly, you know, the dermatologists or radiologists here, my friends are in those specialties that even are not related are now, you know, being pulled into those positions. And, you know, we're all doing the best we can with wherever we can. So I think that's really what it is at the end of the day.
Wow. Yeah, challenging times for sure. We actually have a pretty pertinent question coming in from the chat box. What's the state of telemedicine deployment, if any, as a way to screen potential COVID patients? I know I've heard of telemedicine being deployed for basically non-essential appointments, but curious if that's being implemented for COVID patients as well, who are maybe experiencing milder cases.
Right. I mean, I think right now that's certainly the preferred method, right? Like, even people who are experiencing some symptoms, the general advice is, you know, to self-isolate and quarantine yourself, stay at home, wait a few days to see how it progresses. But certainly as soon as it starts to turn further south, then obviously come into the hospital. But at this point, we're trying to you know, keep people at home and isolated as much as possible, because, like, you know, the numbers right now show that 80% of the time these cases are going to be mild, and it's just going to be like the regular flu that you'll just, you know, power through it and kind of get past it. And so what we don't also want is to increase the risk of this spreading further, right? So getting past the incubation period, essentially, or the period where you're going to be most likely to infect more people, other people, is essentially the whole rationale behind doing the social distancing and the isolation and self-quarantining. In terms of telemedicine, I haven't directly worked with them in terms of figuring out kind of where it is right now. I know there's a lot of people trying to work on that, especially now that a lot of the regulations behind crossing state lines for practicing medicine have just been kind of peeled back for this case. And so I think that's going to be up and increasing. It's going to be a good way for figuring out how do we monitor these populations who are more at higher risk as well, or who are on the recovery path from the disease itself. Because, you know, I mentioned that at Mount Sinai we were already starting to do convalescent plasma. One of the areas is like, we need to know when people have essentially resolved from, have essentially gone past the infection, now are over it, and now have essentially started to develop the antibodies against the virus. Because then we need to, from there, be able to bring them into the hospital to get them tested again, to make sure their viral loads are low enough, and to make sure they built up enough antibodies in their systems to be able to collect some of that plasma for transfusing into the patients who might need it.
I see. And we have a question coming in, you know, from Mark. asking how should people who have had the virus, what do they do afterwards? Are they, do you just monitor them, or are they safe to re-engage and go about their normal lives?
So I mean, I think currently we don't have a good sense of exactly how long that tail end would be. Right now, it's essentially been about 14 days is what we tell people to self-quarantine for. Some places are saying maybe closer to 20 days. So I think that's kind of the hard part to determine. What we don't essentially want to end up being the case is like people reintegrating back into the general public too early, and still being contagious and kind of continuing to spread the infection. Because then the concern too is going to be secondary infections or kind of second waves of infection, especially if the virus does start to mutate. At this point, there's very low likelihood, given what we know about the virus, that it would mutate into a different strain. But however, that can always be a risk for sure. So I think at this point, it's still as much as you can social distance, self-isolate, until at least on a more population level, we have a better sense of how well contained the virus, the infection is.
Mm-hmm. And Freddie, is there more information coming out about asymptomatic carriers and whether that's rare or whether that is something that we should really be concerned about?
I know that's a high interest out there. We just don't know enough information about it yet, because at this point we don't have enough people tested, and that's really the thing, right? Like, we don't know who's an asymptomatic carrier because the only people who are getting tested right now are the people who are very symptomatic. Right. And so that's going to be challenging for us to know. I mean, I think we would love to know that information, but we definitely have to expand our testing capabilities, whether it's through current tests or development of new rapid tests, which, you know, a lot are being worked on, but still have a fairly significant false negative. I think from the numbers I've heard is at least even these new rapid testing, something as high as 30% of cases are still false negatives, meaning that, you know, they're coming up as negative, but they're actually positive cases.
That means only 70% are really being caught. So if you test 100 people, there will be 30 people who have it, but the test will say negative.
Well, sorry. I mean, I guess I should refer, if you test 100, if 100 of the positive, no, I think, yeah, you're right. Sorry. Been a long day. Yeah, that 30 of those people would still have it, but they wouldn't be caught as having it.
I see. Wow, that's something that hasn't really been talked about. I think there's a lot of information of rapid testing going out there. We have a question from Rich about on the regulatory side, if there's been a streamline in approval of drugs, credentialing, training of healthcare workers, if that train has been moving on the public side.
So on the regulatory side for therapeutics, I think the FDA has certainly done a lot to expedite the process. It's still not, I mean, obviously, you can always ask for it to be even more accelerated, but certainly it has been gone leaps and bounds. I mean, even in the amount of testing capabilities, I think that's been very true. Right now, I think like even, like for example, for convalescent plasma, we have to file for an emergency IND, but it's not, the emergency IND is not for like a blanket procedure for like all of Mount Sinai to be able to do convalescent plasma. We have to file one of these for every single patient that receives convalescent plasma. So even some of those are a little bit complicated. And then all of these still have to go through not just the FDA, but also internal IRBs to be able to have the use of this as well. So, and then I think on the training and credentialing side, I don't know if there's been more progress there. I mean, I think they're trying to loosen a lot of those things, like the practice across state lines has been peeled back. I think people are trying to figure out how to better facilitate, again, retired people or people who have left the workforce to come back in more quickly. in terms of recredentialing or malpractice insurance or liability insurance aspects. But hopefully that will continue to move in the right direction.
Mm-hmm. Great. All right. Hopefully some silver linings. We need it during this time. Yep. So what can us lay citizens do besides, following the orders of staying home and not hoarding masks? We have a question here. Should normal citizens wear masks to slow the spread?
It's a challenging question to answer, mostly because, again, although some health systems have better supplies than others, we're certainly not out of the woods yet in terms of having enough masks around for even protecting the healthcare workforce. So at this point, I think follow what the CDC recommends in this area, or your local hospital recommends as well, because it's also going to be different from city to city, right? Depending on the infection rate or what percentage of the population is expected to currently have, or at least at what part of the curve, so to speak, as infection spreads that we're at. I think at this point, it's just limiting as much of the interactions with others as possible, which I know is hard and it's driving everybody stir crazy, which is, again, one of the reasons that we decided to launch the COVID-19 challenge, to give people essentially that peace of mind of being able to do something meaningful and impactful, and making the best use of their skills and talents towards solving some of these problems.
Right. Yeah, and I think that Zoom is everyone's best friends by now, if people weren't already using it before.
It's quite amazing that Zoom is the one that has come to the top and not, the litany of others like WebEx and Skype and all these others.
Yeah, Zoom has kind of been the winner here. And I guess personally, I've been experiencing Zoom technical issues. I think it's just because they're so overloaded. So yeah, certainly. Do you think that this will change, how do you think, when this is all said and done, I know this may be too early to be asking this question, how this will change the face of America and the healthcare system and doctor-patient relationships?
I think there's a lot of opportunities there, especially if you think about it from the healthcare innovation perspective. It's, I think, really putting a big injection into hopefully the promise of telemedicine and telehealth that we've talked about for so long, or digital health solutions in general. And I think it's not just healthcare, but it's thinking about everything we do, right? Going from the whole work from home and how does that really correlate with productivity and efficiency of the workforce, to remote education and virtual education, right? Can we now really make that leap into those next chapters? Because I think, we've always talked about like this would be the great equalizer, right? To be able to now spread the access to remote areas, to underserved areas. And so this will be a true test of if we can, actualize on that. And I think people are not, we're so focused on sort of the negative side of what's going on, which is understandable, but there is a lot of opportunities at hand that, can be explored, because especially now as a lot of the regulations are being essentially temporarily scaled back, there's a lot of ways for new innovation to rapidly come to the forefront without as much of the hindrances as we used to have. On the innovation side, especially in the context of this COVID-19 challenge, it's a real test to see, can these public-private partnerships, this use of rapid agile development in terms of ideation, creation, solution development, prototyping, et cetera, can happen on that quick of a scale within the healthcare system. Because I think everyone readily knows, especially if they're in this space, medicine moves at a very slow, snail pace. And medicine as a field is a very conservative field. And usually changes doesn't happen until we have generational turnover, or until we have essentially the younger people rising up into those stages and providing that innovation process. But so I think it'll be interesting if we can take advantage about building these new innovation pipelines that can rapidly go from ideation to solution and to implementation. Will those end up sticking? It's really going to be test to see if any of these things that we do right now in this current context will end up sticking afterwards for the better.
Yeah, I hope so too. I hope that, you know, once we're out of the woods, you know, there will be some silver linings there with innovations coming out of this that will, you know, be useful for society and the world going forward. All right, and for those on the call, we are monitoring our chat box, so please continue to type in your questions, and we'll answer it in the order it was received. I'm going to go back to an earlier question from Bing asking, what is the survival rate once a person is admitted to the ICU for coronavirus?
That I don't know off the top of my head. I think that's highly dependent on which system that they're coming into, and also what the patient's status was and comorbidities was at the time they were admitted to the ICU. So I think that would be a highly variable answer for sure.
Right, and it all depends on who's coming in, right? How sick they are and what the sample.
I mean, at least, especially right now at this stage and point where we still have the ICU facilities available and we still have ventilators and so on. So I'm sure it's going to get to a point where that might even be a concern too. If only the sickest of the sickest are going to be able to even get into the ICU.
Mm-hmm. Right. And I guess, is there any promise for treatment regimens? I know there's a lot of experimentation with some antiviral drugs. Do you see movement on that front, and any promise?
I mean, I think it's still too early to say. There's certainly a lot of experimental trials that are being run right now to try and test and see. I think the limitations is still, again, getting enough patients accrued into those trials to, to know for sure. I mean, you've seen, for example, like around chloroquine, there's been a lot of mixed reviews in terms of, its efficacy towards this or not. And so I think that we need a little bit more time to figure out. But I think part of it is also related still to our testing capabilities, because again, if we don't have a good ways or enough tests to be able to constantly monitor these patients as they're going through their treatments and monitoring their viral loads, we're not going to have a true answer either.
I see. So we still have to just take a pulse and learn as we go.
Yep.
Okay. We got a few questions actually about how non-healthcare related professionals can help out, and I know you covered this in the beginning with who can participate in the COVID-19 challenge, but I guess any other words for us on the call who are not healthcare related and how we can contribute and help out.
I mean, I think there's a few. I mean, there's a lot of obviously different players out there trying to do just that, right? Trying to figure out how do we unlock this potential of people who want to help, who are not in healthcare but have different value added, right? So, and it kind of depends on what skill set you can bring to the table. But I think MIT definitely has a lot of different avenues for it. I know the MIT Innovation Initiative has put together, I think, a rapid innovation dashboard, which consolidates all of the efforts by various MIT entities across campus and I think beyond campus on projects specifically towards COVID-19. So I think that's one good place to start as well in terms of seeing how to contribute there on a meaningful level. Otherwise, would be trying to work with your local hospitals and communities, because as we continue to stay pretty much in shelter in place and lockdowns across the country, everything is going to become highly localized. And so having a good sense of what that system looks like, where they need the most help, where can, what kinds of things can you do prior to, the surges that will come. So I think that's, and then I would say the last part is, keeping a watchful eye on your friends and your colleagues and your loved ones, and, especially the ones that might be at higher risk if they do get the virus. And making sure that they, people know how to do proper social distancing. Even the whole concept of self-quarantining, we keep saying, yeah, that means you staying at home, right? But it also means you staying at home and away from everybody else that's in your home.
Right.
If you're sharing a bathroom, if you're sharing a kitchen, like, it means everybody in the home is still going to get infected by it. So it's kind of things like that. But
I see. And I guess, could you summarize again who the highest risk populations are, and whether that's still, whether that's been redefined, and if there's been any other correlations with other health conditions?
I mean, I think right now, based on the information I've seen, certainly the older population is at higher risk. I think the older, especially as you go above 60, the older you go, the higher the mortality rate becomes. The others, I think there seems to be a higher predisposition that males are more affected than females. And then usually the most, in terms of comorbidities, so to speak, it's essentially people who are a precondition for respiratory diseases to begin with. So, that's what predisposes them most towards the higher complications from the virus. But, even for that, I would, refer back to the CDC as well and WHO in terms of who, on a more larger basis or national or global basis, what the at-risk populations are.
Great. Thank you for that clarification. All right, we have a more philosophical question. I know you're pretty tired, Freddy,
Okay.
but we have a
No
more personal philosophical question coming in here, asking, certainly this has been pretty wild for you, and this is probably not what you anticipated as your first year of residency. So how has your experience with this pandemic so far changed your perspective as a healthcare practitioner?
My perspective, I think I would say in two ways. One is that it's been really great to see that the healthcare community really come together and join forces and really like just drop all of these barriers that are, to be perfectly honest, are a lot more posturing in politics than anything else, and just really getting the job done. And I would say the community support behind supporting our healthcare workers, I think, has been fairly phenomenal as well. And I think, that's, testament to, going back to why we all got started in medicine, which is the patient-physician relationship, and that bond between the healthcare provider and the patient is really paramount. And that's really what drives all of us in healthcare, or at least I hope that's what drives all of us in healthcare towards what we do and what we've always done. But it's really, again, the community coming all together to do its part to solve the problems, right? Like, as long as people continue to do social distancing, isolate themselves, only come in when absolutely necessary. You let essentially us be able to do our job, which is to take care of the sickest of the sickest. And then as we get better capacity to go back to more normal stage of taking care of everyone.
Thank you, Freddy. All right. Do we have any more questions on the line here? All right. We have a question about, okay. This is an interesting question. This is about healthcare workers, how risky it is for them to return to their families after tending to COVID-19 patients. It's an interesting idea. If the risk is high, can we devote hotels near hospitals for the healthcare workers?
So I think there's certainly a higher risk. We don't know exactly how much higher it is, especially, I mean, we do, practice safety precautions, and we wear our PPE as well. We've taken extra precautions too in terms of ensuring that we now all change at work instead of taking any of that home with us as much as possible. So we don't quite know yet how much riskier it is given the way we're currently practicing. I will say, at least from what I've heard in China, is that one of the things that's been attributed for how well they've been able to fund the curve, so to speak, is that the healthcare workers were isolated away from their families during this time, and they were put into sort of separate living quarters. I'm not sure if it was necessarily hotels or if it was temporary facilities that were built up. But to the person who asked the question, I mean, that's certainly something that we can think about. Hopefully we get to that high of a risk, but certainly an option worth considering for sure, of how to essentially isolate the high risk population in terms of spread. But the other part too is, again, high risk of the population that's going to have major complications if they do get the virus, right? Because the other way to think about it too is, like, even the the healthcare workers who have gotten exposed and are now past, don't have any symptoms and are essentially asymptomatic, they've now started to build up immunity to it. And so, once they're past that incubation period, the likelihood that they'll have the virus again is going to be very low. And so at that point, there's not a risk for them spreading it to others.
Oh, that's interesting, the approach that China took there. All right, I have a question about how the public sector, I know we touched bits and pieces on this throughout our conversation, but if President Trump were listening to this webcast right now, what are the three wishes you would have for our government leaders right now?
I would say to listen to the healthcare workforce, listen to our scientists, and to the science experts out there about this disease, and to really give them that power to establish the rules, essentially, of what should be happening. I think he's starting to do some of that more recently, but really that's the paramount of it all. I mean, I know a lot of people are talking about the economic downfalls and what's coming out of this, but at the end of the day, if people die, that's really first and foremost. Economy can survive, but a person dies, they don't come back. In terms of me listing out three things, I would say listen to this, medical and scientific experts to unlock as much of the powerhouse that is the US, right, in terms of manufacturing, in terms of ingenuity, to really work on solving these problems, and using whatever power is at hand to do that. And I think thirdly, learning from what other countries have done and doing better coordination of, because China was at the forefront before we were, right, and Italy was too, and like being more conducive to sharing of that information across the globe, and supporting those efforts as well.
Great, thank you so much, Freddie. We are at the top of the hour, so we just want to say thank you. Your well-being is our well-being, so thank you so much for being on the front lines. We salute you, and we wish you, health and safety, and so grateful that you were able to take this hour out of your crazy busy schedule to talk to us today. So thank you so much Freddie, we will be thinking about you, and everybody, if you visit the website, covid19challenge.mit.edu, please check it out. All right, thank you all.
Thanks, everyone. It was a pleasure.